Hello everyone. Today we are going to learn about central nervous system infection in children. Are you ready? At the end of this lecture, the students should be able to understand the terminologies associated with CNS infection, pathogenesis and etiologies, symptoms and signs, investigations to diagnose, treatment options, and complications of CNS infections in children. Let us start with a case scenario. A 4-year-old girl was brought to the emergency department with history of seizure for 15 minutes. Further history revealed that she had fever for the last 3 days and appeared listless for a few hours before developing the seizure. Her mother also noted that she requested that the curtains in her room to be drawn down as she hated the light that was shining into her room. She was never vaccinated. On examination, her temperature was 39 degrees Celsius. Her pulse rate was 150 beats per minute and her respiratory rate was 50 breaths per minute. Her blood pressure was normal. She had neutral rigidity and Koenig's sign was positive. Pupils were equal and reactive to light. Her muscle tone was generally increased as she was still having seizures when examined. What is your provisional diagnosis? What is the appropriate initial management in the emergency department? What investigations should be sent for this girl? What would be the most appropriate definitive treatment for her? Try to answer these questions now. Keep your answers and compare with the ones given at the end of this lecture. Infections of the central nervous system are among the most devastating infectious diseases and cause high rate of death and disabilities worldwide. They often present as medical emergencies. Thus early appropriate care is critical in reducing the morbidity and mortality associated with them. Central nervous system infections commonly manifest in children in the form of meningitis, encephalitis, or combination of both called meningoencephalitis. Meningitis is defined as inflammation of the meninges. Encephalitis is defined as inflammation of the brain parenchyma. And meningoencephalitis is a combination of both. These inflammations can be due to infections caused by various bacteria, viruses, fungi and protozoans. This picture shows the layers of the skull including the meninges. The meninges is actually made of 3 layers, namely the dura, arachnoid, and pia mater. It slots between the skull bone and the brain itself. Worldwide, bacterial meningitis accounts for more than 1 million cases and 135,000 deaths annually. Neurological complications occur in 9 to 25% of these cases. Children under 5 years of age are more affected. In Malaysia, Hussain et al. Reported that overall incidence of childhood meningitis in the first 5 years of life was 76.7 per 100,000 children per year. In another study, Erliana et al. Reported that majority of childhood meningitis occurred under 5 years old. In the United States it was estimated that about 19,000 hospital admissions and 4,000 deaths are due to encephalitis every year. In Malaysia, there is no data available on the overall incidence of encephalitis. Encephalitis in Malaysia tends to occur in outbreaks and we do have data on Japanese encephalitis, which outbreaks are common in Sarawak. Between 1997 to 2005, the annual incidence of Japanese encephalitis in Central Sarawak was estimated to be 7.9 cases per 100,000 children ages 12 years and below. Pathogenesis. Pathogens must first gain access to central nervous system to cause the disease. The commonest pathway is through hematogenous spread, where the infection actually occurs elsewhere in the body but it spreads to the brain via the bloodstream. Another route is retrograde access via the neuronal pathway. The third route is through direct contiguous spread via adjacent structures such as middle ear or cribriform plate of the nasal bones, especially if there is defect due to fracture, infection or presence of foreign bodies. Central nervous system infections, as previously mentioned, can be caused by bacteria, viruses, fungi and parasites. Although meningitis has many possible etiologies, the bacterial ones are more important as it is associated with more serious outcome compared to the others. Common bacterial causes of meningitis include Streptococcus pneumonia, Neisseria meningitidis and Haemophilus influenza. Examples of viral causes of meningitis include enteroviruses, echoviruses, coccidioviruses and mumps. Fungal meningitis can be caused by Cryptococcus, whereas malaria is an example of parasite which can lead to meningitis. Encephalitis is usually caused by viral infection. The commonest virus causing encephalitis worldwide is herpes simplex virus type 1. Other causes include varicella zoster, measles and enteroviruses. In Malaysia, outbreaks of encephalitis are commonly caused by Japanese encephalitis or Nipah virus. However, bear in mind the etiological agents mentioned are the common ones and just the tip of the iceberg. The symptoms of meningitis or encephalitis in babies and young children are relatively non-specific. They may present with fever associated with irritability, inconsolable crying, high-pitched cry, seizure, lethargy, poor feeding or vomiting. Other than fever, older children with meningitis may complain of headache, neck stiffness or photophobia, in which case they prefer to stay in the dark rather than bright rooms. On the other hand, children with encephalitis may be drowsy and confused in time, place or person, not knowing the time of the day or where they are, as well as not recognizing familiar people. They may have hallucination, i.e. seeing and hearing things that aren't there. Apart from that, they may exhibit changes in personality or behavior. Beside the symptoms, other aspects of the history are also important. Duration of the symptoms and presence of any comorbid conditions or pre-existing illnesses need to be sought. For example, a child who is immunosuppressed or has history of previous cranial-related surgery is at higher risk of developing central nervous system infection. Drug history, traveling history especially to an area with a known outbreak, and history of contact with human with similar symptoms, exposure to animals such as pig or history of insect bites need to be elicited as well. Signs in central nervous system infections are usually not pathognomonic for either meningitis or encephalitis. On examination, the child may have high-grade temperature, appear lethargic or irritable. He or she may also have signs of sepsis such tachycardia, tachypnea, poor pulse volume, reduced capillary refill time with cold and clammy peripheries. However, there are certain signs which increase our suspicion of CNS infection. For example, babies with meningitis may have bulging fontanelle. Nuchal rigidity with positive Kernig's and Brudzinski's signs are indicative of meningism or meningeal irritation. Although the sensitivity is low, meaning the absence of these signs do not exclude possibility of meningitis, they are highly specific, which means that the presence of these signs are highly suggestive of meningitis. Please take note that these signs are especially unreliable in infant and should be sought only in older cooperative children. To elicit the Koenig's sign, patient is kept in supine position. Hip and knee are flexed to a right angle, and then knee is slowly extended by the examiner. The appearance of resistance or pain during extension of the patient's knees beyond 135 degrees constitutes a positive Koenig's sign. Video on how to perform Koenig's sign is shown here. Brudzinski's sign is performed with the patient in supine position. To elicit this maneuver, the examiner keeps one hand behind the patient's head and the other one on the patient's chest in order to prevent the patient from rising. Reflex flexion of the patient's hips and knees, after passive flexion of the neck, constitutes a positive Brudzinski's sign. Video on how to perform Brudzinski's sign is shown here. Investigations. General investigations include full blood count, urea and electrolytes, serum glucose, C-reactive protein and blood culture. Diagnosis of CNS infection is confirmed by performing cerebrospinal fluid analysis obtained through lumbar puncture. Radiological imaging such as CT or MRI of the brain is indicated in certain cases to support the diagnosis. General investigations include the following. The full blood count may show leukocytosis with neutrophilia in bacterial meningitis. Renal profile may show raised urea level with normal creatinine if the child is dehydrated. This can occur secondary to vomiting and poor oral intake, which are common symptoms in patients with CNS infection. The sodium level may be low if the patient develops syndrome of inappropriate antidiuretic hormone secretion or SIADH, which is a relatively common complication of CNS infection. In this case, an excess of antidiuretic hormone is secreted, leading to water retention with consequent dilutional hyponatremia. The serum glucose should be checked. This is because the interpretation of cerebrospinal fluid glucose requires its comparison with the serum glucose. C-reactive protein is raised in the presence of inflammation or acute bacterial infection. Patients with bacterial meningitis complicated with septicemia may have growth of the causative organism in the blood culture. Cerebrospinal fluid or CSF can be obtained through a procedure called lumbar puncture. Definitive diagnosis of meningitis or encephalitis, and also their possible causes, can be made by doing some specific test and analysis on the CSF sample. Lumbar puncture is a method to obtain cerebrospinal fluid for analysis. It should be performed as early as possible if CNS infection is suspected, preferably before antibiotic is administered. Contraindications to lumbar puncture include raised intracranial pressure, as it may cause the patient to have brain herniation, bleeding diateses such as coagulopathy, and skin infection at site of puncture. CSF analysis. During lumbar puncture, the cerebrospinal fluid opening pressure can be measured and it is usually high in bacterial meningitis. The cerebrospinal fluid should be grossly inspected. It appears turbid or cloudy in bacterial meningitis. Then, the CSF should be sent to the lab for microbiological and biochemical analysis. Microscopic examination after gram staining may show the presence of bacteria, red and white cells in the CSF. If white cells are present, the percentage neutrophils or lymphocytes should be noted. Several tests can be done to find the causative organism. These include CSF for culture, bacterial antigen test and polymerase chain reaction. If the CSF culture reveals the growth of a specific bacteria, its antibiotic sensitivities should be tested. The bacterial antigen test is available for the 3 common causes of bacterial meningitis in children, i.e. Streptococcus pneumonia, Haemophilus influenza and Neisseria meningitidis. This test is especially useful if the child has received antibiotic prior to performing lumbar puncture, as will be discussed later. Polymerase chain reaction or PCR is mainly used to confirm the diagnosis of viral encephalitis such as herpes simplex type 1 and varicella zoster. Biochemistry analysis includes measurement of CSF protein and glucose, which is important to differentiate between bacterial and other causes of meningitis. These are the findings of cerebrospinal fluid according to different causative agents of meningitis. In bacterial meningitis, the white cell count in CSF is raised with neutrophil predominant. The CSF protein is raised whereas the CSF glucose is low compared to serum glucose. Gram stain may be positive. For example, we may see gram-positive cocci in the case of pneumococcal meningitis. The culture will grow the causative bacteria unless the child has received antibiotic prior to performing lumbar puncture. Findings in viral meningitis are similar to encephalitis, in which case the white cell is usually slightly raised with lymphocyte predominant. Both the protein and glucose are normal. Brain imaging either with CT or MRI is useful to support the diagnosis of CNS infections. For example, CT brain with contrast may demonstrate meningeal enhancement in meningitis. MRI brain is particularly useful to show typical changes in temporal lobe associated with herpes simplex encephalitis. Brain imaging is also indicated if we suspect that the patient has developed complications of CNS infections such as hydrocephalus, brain abscess or subdural empyema. These are MRI brain images of a patient with encephalitis. Note the hyperdensity areas in the right temporal region as indicated by arrows. This is a typical finding in herpes simplex virus encephalitis. These are MRI brain images of a patient with meningitis who developed obstructive hydrocephalus. Please note the enlarged ventricles as indicated by the arrows. This slide shows 2 different radio imaging of the same patient with brain abscess. Image A is a CT brain with contrast, showing a ring-enhancing mass as shown with asterisk, with associated mass effect as shown with black arrow, and surrounding edema as shown with white arrow in the left frontal lobe. Image B is an MRI showing fluid level within the mass as shown with dotted white arrows, and also extensive edema surrounding it as shown with white arrow. This MRI brain shows bifrontal and bitemporal subdural abscess in a patient with meningitis. The treatment of CNS infection can be divided into general and specific treatment either for meningitis or encephalitis. General treatment. Firstly, we give symptomatic treatment such as antipyretics if the child is febrile. Control the seizure if present. Rectify electrolyte imbalance and dehydration, as well as watching for symptoms and signs of increased intracranial pressure which may necessitate intensive care monitoring. Intravenous antibiotic is the mainstay of treatment for bacterial meningitis. It should be commenced empirically once meningitis is suspected. Please remember that antibiotic should not be delayed even if lumbar puncture cannot be performed either due to presence of contraindications or lack of parental consent. Please click the word empirically to see the choice of antibiotics that can be used. The antibiotics can then be adjusted once the organism is identified and the antibiotic sensitivities are known. If the CSF analysis is negative and meningitis is excluded, The antibiotic can be stopped unless there is another source of infection that necessitates its continuation. Empirical antibiotics for pediatric patients with suspected meningitis are usually a combination of intravenous penicillin and cefotaxime. However, in patients who are 3 months and older, intravenous ceftriaxone is a good alternative as the dose frequency is less. All of these antibiotics have good blood-brain barrier penetration. Duration of treatment varies from 7 to 21 days depending on 1. The age of patient, 2. Causative organism, and 3. Whether there is associated complication or not. Beside antibiotics, steroid was proved to have a role in the treatment of bacterial meningitis. The rationale behind its use is that the inflammatory cascade triggered in patients with bacterial meningitis leads to tissue damage and worsening of neurological sequelae. This response is exaggerated by bacterial lysis and endotoxin release resulting from administration of antibiotics. Steroids can reduce this effect with its anti-inflammatory property. Studies have shown that dexamethasone is beneficial when given prior to, or with the first dose of antibiotics in children with meningitis. However, there is no evidence that it confers benefit in all but Haemophilus influenza B and pneumococcal meningitis. So its use in clinical practice should be considered in case-by-case basis. The treatment of encephalitis is a multidisciplinary approach and it has to be started as soon as possible. Antiviral treatment that is widely used is acyclovir, which is the drug of choice for herpes simplex and varicella zoster encephalitis. Besides medical intervention, physical and cognitive rehabilitation are needed to minimize long-term physical and cognitive problems. CNS infections can lead to acute and long-term complications. Some of them have already been mentioned before. Acute complications. One of the common and serious acute complication of CNS infection is raised intracranial pressure or ICP. In one series, cerebral herniations were seen on autopsy in 30% of children who died of meningitis. Subdural effusions are fairly common, especially in Haemophilus influenza meningitis. These usually do not require intervention unless there is persistent fever, focal symptoms or evidence of rising intracranial pressure. On the other hand, subdural abscess and brain abscess require drainage. Cranial nerves can be damaged either directly or indirectly due to increased intracranial pressure. Long-term complications. Hydrocephalus and epilepsy are potential long-term sequelae. Sensory neural deafness is the most common long-term complication. It occurs in 5–30% of cases, especially in pneumococcal meningitis. The most disastrous complication of CNS infections is cerebral palsy, which leads to global developmental delay. CNS infections can lead to acute and long-term complications. Some of them have already been mentioned before. CNS infection is not very common, but they can lead to serious debilitating effects. There are many causes of CNS infections and the clinical presentations are very not specific, especially in young children. However, certain aspects of the history together with specific findings on physical examination may assist in the diagnosis. CSF analysis via lumbar puncture is an important diagnostic tool. Close monitoring and early treatment are paramount in the treatment of CNS infections. Let's look at your answers for our clinical scenario. What is your provisional diagnosis? The answer is meningitis. Seizure, fever, photophobia, nuchal rigidity and positive Koenig's sign point toward meningitis. What is your initial management? Give oxygen. Put in left lateral position. Suction if needed. Administer per rectal diazepam. Insert IV line. Take bloods. Give intravenous diazepam if seizure is still not aborted after 5 minutes. What investigations would you like to send? Initially FDC, serum urea and electrolytes, glucose, blood culture. Lumbar puncture once she is more stable. Specific treatment: intravenous ceftriaxone. That's all about central nervous system infection in children. Try to test your knowledge by attempting the questions in quiz section. Good luck!